So how many of you are using contrast now in your hospitals?
None.
None. Okay.
It's just started, I think, in 2 institutions in the kingdom or 3 maximum.
King Faisal
Just
Hospital
started.
use. King Faisal Specialized
Yeah, just
Hospital use.
started as a trial.
Okay. So it was just approved in the United States last year, but we've been doing it off-label in studies for a long time. So I consider this as just another tool that we can use for imaging, and I think you can see after my talk that it will improve patient diagnosis and outcome. There are many advantages to ultrasound contrast. One is the real-time assessment of vascularity. So in CT and MR, we take snapshots in time. So you may get an arterial, a portal venous, and a delayed phase. But here we are getting 30, 40 frames a second for 5 minutes. So things like hemangioma, where we want to see it fill from the outside in, we can see very well. Focal nodular hyperplasia, we can actually see the spoke wheel in every case, and makes it an easy diagnosis. The ability to subtract out background soft tissue, so we get a contrast-only image, is also very important, particularly when you're looking at things that do not have very much enhancement. So things like a papillary renal cell carcinoma may be very difficult to diagnose because they have very little enhancement. And without subtracting that background tissue, you may not see that. The narrow ultrasound beam allows for improved visualization of vascularity in small structures such as septations or small mural nodules. So this is very helpful in cases of cystic renal cell carcinoma, where we can actually see these small nodules enhancing in the septations, which is very hard to see in CT and MR because of volume averaging. There's no radiation. These are true intravascular agents, so they do not extravasate like MR and CT agents. So in some cases, particularly cholangiocarcinomas, we do get a different appearance with ultrasound contrast than with CT and MR. Most of the other things are about the same. Short half-life, between 5 and 10 minutes, and allows us to give multiple injections, and no renal or hepatic toxicity. So we end up using this a lot in patients that need a contrast exam but can't get an MR or CT. These are better tolerated than CT and MR with fewer and less severe adverse events, not nephrotoxic, and safe for use in renal failure or renal obstruction. And CUS can be used to image the microcirculation and to quantify perfusion using a bubble destruction and reperfusion technique. The disadvantages are that you need an IV, and I don't know in Saudi Arabia, but in America, we have most CT and MRs is not a problem, but ultrasound is not used to this, and this seems to be, for many places, the biggest obstacle. You need 2 hands because you need the sonographer to be doing the exam while the person's injecting. You get a large amount of data. So if you save the entire 3 or 5 minute clip, you really can't send it to your PAC system. So most systems will allow you to save a clip and then go back and either crop small portions of the clip or just send individual images to the PAC system. If you want, all of the systems have a USB port in the back. You can get a 4 terabyte drive and you can send the entire clips and not send them to the PACs so that you have them. And you need to buy the additional software on the machine to be able to do this. The microbubbles are gas bubbles stabilized with a lipoprotein shell. The agents vary in their gas content and shell makeup. The bubbles are smaller than a red blood cell, but large enough not to extravasate, and these bubbles have a nonlinear response to low MI ultrasound and bursts at high MI. So you need this contrast-specific software to do these. You need the contrast agent, and I was told SonoView is approved for use in Saudi Arabia. So that's the only agent that's approved for the US at this time. Also, for abdomen, we have Definity, which is sold by Lantheus, and we have Optoson that's sold by GE that are approved for cardiology in the United States, but not yet for abdomen use, but we can use them off-label. And again, you need to figure out what's going to work in your institution for IV access. In our lab, everybody starts IVs except the ultrasound people. So usually when we need this, somebody comes from one of the other sections to start that, and then they stay and do the injection. So what is this contrast-specific software? So it allows low and high techniques and dynamic evaluation of contrast in all phases. The pulsing schemes are in pulse inversion, pulse modulation, or combinations, and each vendor has what they think is best for their machine. These are things you don't really need to worry about. And these consequences take advantage of the nonlinear response to microbubbles. So to explain what happens, so pulse inversion is the easiest sequence. So the machine will send in two pulses out of phase, so one at 0 degrees and one at 180 degrees. So the tissue gives you a linear response, so when you take them out of phase images and you add them together, you have no signal. But the microbubbles are nonlinear, so they give different responses, so when you add them together, you have a signal. So therefore, we end up with no background signal, and we have contrast signals, so we only see contrast. Now, we can also do something different. Instead of adding these two, we can subtract them. So now we can do a B-mode image that may not be as good as our standard B-mode image, but we can have real-time B-mode imaging and contrast at the same time. So again, you have the same, we call it Lumison in the United States because the FDA, but it's Sonoview in the rest of the world. And it's approved for us for focal liver lesions in adults and pediatric patients. Again, Lantheus has Definity and GE has Optison, which are used for cardiology in the US. I don't know what happens in the United States. Each state has its own requirements of who can start an IV and what their training is. But you do want to use at least a 20 gauge needle because the bubbles are very fragile. And if you increase pressure when you inject or they're compressed, then they will bust and you won't have any contrast. So we need one in a larger IV. And we like to use a 3-way stopcock with contrast parallel to the IV and saline perpendicular, and I'll show you a picture of that. So, I don't know, again, informed consent. We no longer have to give a written informed consent in the United States, and again, I don't know what your regulations are, but we tell the patient they're getting an injection, and the volume is very small compared to CT and MR, and that the reactions are possible, but they're less than CT and MR, we don't expect them to have any problems. And again, if we do it off-label, we explain to them we're giving them the same dose, we're just putting the probe in the other position. So to do the exam, you're going to do your normal examination, and when you're doing that, you want to find the lesion, and you want to find a plane that the lesion is going to stay in the plane as the patient breathes. So oftentimes in the liver, you're going to do like a longitudinal image. And the reason is you're going to look at the contrast on every frame. And if you have the lesion going in and out of the frame, it becomes very difficult. So if you can align the patient, so if they just do normal breathing, the lesion stays in the plane, you'll be able to follow it. All these drugs require some type of activation, and I'll go over that shortly for Sonoview, but the other two agents also require activation. You need to make sure you activate your contrast-specific software. Almost all the vendors now have software that's pretty automatic. You just hit the button, and for the most part, you don't have to deal with the settings. The only thing you would want to do is the contrast image before you inject bubbles should be black. You should have very little signal because you're only looking for bubbles. So you want to turn the gain down, and I think a lot of people get worried because sometimes when you inject, it may take 30 seconds in someone with heart failure to see the bubbles. So you just be patient and watch the bubbles come in. They all have timers. You start the timer. The recommendation is to start that when you inject the saline. So you inject the contrast and then the saline flush, and then you can save the clips or images. So this is the setup we use. So we have an IV. What we like to do is put the contrast in line with the IV, so it doesn't have to go around to bend because you may bust bubbles, and then you have the saline and the perpendicular. So the injection rate is about 1 cc a second, so it's just a nice quick push. If you go too fast, you break the bubbles. If you go too slow, you have a very prolonged peak and you don't get very good enhancement. So this is how you activate SonoView. It comes in a lyophilized powder in this vial. It comes, at least in the United States, with a syringe with a saline and a spike. You attach the saline to the spike and you put it into the agent vial, and then you inject the saline, and then you shake vigorously. And you can see when I just put this in, the fluid is clear, but you want to shake it to make sure all of the powder is dissolved and it's nice, milky white. If you let this sit, it will settle. So you want to continually shake it. And if you pull it up in a syringe and you're going to inject it, and it takes a few minutes longer than you thought, you can just roll the syringe and it'll resuspend the bubbles. The recommended dose is 2.4 milliliters regardless of weight. However, I think modern machines, 1.2 is more than adequate, and some of the newer machines actually were using half of that, so like 0.7 or 0.8. So as the machines are getting better, we're using less and less contrast. For livers and kidneys, that's about a standard dose, but for small parts, breast, thyroid, testicles, because these do not have as much vascularity, we give a full dose. So we would double what we do for liver or kidney. The recommended dose for pediatric patients is by weight. You can give a second injection. And again, the package labeling, at least in the United States, is not exceed 4.8 milliliters. But I will tell you, when we did phase 2 trials for Definity, one of the other agents, we were injecting 30 times what we use now and no one had problems. So it's very safe. And if we're doing interventional procedures and we need to do more than 2 injections, we do that. Again, you want to save images. I think it's important, if you're looking for hepatocellular carcinoma, we look for washout, and sometimes it doesn't happen until 5 minutes. So if you're really worried about a hepatocellular carcinoma, you need to scan the patient for a minimum of 5 minutes, preferably 7 minutes, to see if you see late washout, because this is often a characteristic of hepatocellular carcinomas. You may not want to save the entire clip because it's so long. So what you can do is we usually take a clip from when we first see the bubble to just past the main arterial phase, maybe wait 30 seconds and do a portal venous clip of 10 or 15 seconds. And then every 30 seconds take another little clip just to see if there's washout. So that way you're not busting bubbles with insonating, and you also don't have so much data that you need to send to the PACS. So interpretation, liver, contrast washout is indicative of a malignant lesion. Globular peripheral enhancement, as in CT and MR, is diagnostic of hemangioma. And FNH has spoke wheel arterial rapid intense filling and becomes iso-intense. So here's a little table that I made up of all your options that you can see. And again, hemangioma, you're going to get globular peripheral enhancement. It's going to continue to fill in and will become isodense at the delayed phase. Focal nodular hyperplasia, you'll see the contrast start from the center of the lesion and come out with the spoke wheel appearance, and then it will become again isodense with the liver. Adenomas are somewhat similar to FNHs, but instead of the flow coming from the center out, it comes from the outside in, so it will rapidly fill from the outside. And one of the advantages with ultrasound contrast is that you have high frame rates, and this will happen so fast you may not see it, but you save the cine clip, you can easily cine back at a slower frame rate and see these changes occur. And the same thing with the flash hemangioma. Some hemangiomas just fill real fast and you don't see that globular peripheral enhancement, but if you go frame to frame, you'll see that they actually do fill in a globular peripheral enhancement. So everything above this red line becomes isodense or stays persistent enhancement and is benign. Everything below this, the main characteristic is washout. And depending on the lesion, so in general, metastases wash out within the first minute. So they rapidly enhance and then rapidly wash out. Hepatocellular carcinomas, usually don't start washing out till 3 to 5 minutes. Cholangiocarcinoma is between 1 and 3 minutes. So you can get an idea of the pathology just by when things start to wash out. I'm not going to go through these in detail. These are the indications based on EFSM and the World Federation guidelines. But basically, I think you can use these lesions to characterize focal liver lesions that are L3, L4, or L5. Again, we use this a lot in patients that we can't give contrast to. One issue that we have in the United States is that for oncology, there are relatively defined protocols of how to work up the patient, and ultrasound contrast is not yet in those protocols. So we're having a hard time getting oncologists to send us patients, except if they can't get a CT or MR because of that. So we're working on trying to get that into our guidelines, that this is an option to do. Another thing you can do if you're looking at metastases, if you have one lesion and you see that it washes out very quickly, what you can do then is rapidly scan the rest of the liver to look for black holes where there's no contrast, where you have washout, and you can pick up lesions that are very small that can be missed on CT and MR. So let me just review the literature. So for characterization of focal liver lesions, ultrasound contrast has a sensitivity of 97% and a specificity of 91%. And for focal liver lesions, the diagnostic accuracy increases from 35 to 42%, for unenhanced ultrasound to 87 to 88% by the addition of contrast. If we look at meta-analyses, there were 3 that have been done with a large number of patients. And you can see that the sensitivities are in the high 80s or low 90s, and the specificities are in the 80 to 90% range. The study in the middle was looking at only small lesions, but even with lesions less than 2 centimeters, we still had reasonably good sensitivity and specificity. If we look at prospective studies, the sensitivities were actually better, which is often the case, and the sensitivities were in the mid 90% range, and the specificities were also in the 90 to 95% range. If again, 2 studies directly comparing without and with contrast, and as you would expect, the sensitivities and specificities increase significantly over unenhanced ultrasound. If we look at studies that compared CT contrast with ultrasound contrast, there have been 3, and again, this one I don't like to, I put it here, but I don't think it's appropriate because they only picked up problematic cases on CT, not all cases. These 2 looked at all cases, and you can see when we look at the sensitivities, in both studies, the sensitivity of ultrasound contrast was higher than CT, and as well as the specificities were higher in both studies with ultrasound contrast. If we look at the 3 studies that have been done comparing CT with enhanced MR, similar findings, that the sensitivity in 2 of the studies was better with ultrasound contrast and was about the same in the 3rd, and the specificity of ultrasound contrast was actually higher than MR and about the same in the 3rd again. So in the large meta-analysis comparing all these different techniques by Dr. Friedrich Rust, she said there was no significant difference in specificity, 88 versus 83%, but a p-value that was not significant between ultrasound contrast and CT and MR. But the sensitivity was significantly better with ultrasound contrast than either CT or MR, 95% versus 89%. There was another study that looked at a meta-analysis that included unenhanced CT, unenhanced ultrasound, enhanced CT, gadolinium enhanced MR, and gadohextate enhanced MR, and they found that gadohextate MR was a little bit better than ultrasound contrast, which was second, which was better than all the other techniques, and ultrasound without contrast was the worst. If we look at the sensitivities for individual entities, They're all in the high 80s or low 90%. Just some examples, there's a little hemangioma here, and again, you see this globular peripheral enhancement becoming isodense. And I'm hoping this clip plays. So here on the mind ray system, we can do this where we have the background tissue and then superimpose the contrast, and you can see there are these markedly enhancing lesions in the liver. And they, I'm not going to show you the clip as we go along. At about 30 seconds, they start to wash out. So these were all metastases. FNH, and then these are just clips from a cine clip. And again, here you can see that we've got the spoke wheel appearance starting from the center of the lesion. The lesion then becomes markedly hyper-enhanced compared to the normal liver, and then eventually becomes iso-intense to the liver parenchyma. And let's see if this is going to play. Last time it didn't want to play. No, it's not. Sorry. And again, what hepatocellular carcinoma, marked enhancement in the early arterial phase and washout that's after several minutes. And usually, this is a very significant washout. Usually, it's not quite as washed out. And again, if we compare cholangiocarcinoma to hepatocellular carcinoma, the cholangiocarcinomas tend to wash out a little bit earlier than the HCCs, otherwise they look the same. The appearance of the cholangiocarcinoma is different than MR and CT because these are very leaky tumors, and the contrast from CT and MR leak into the tumor, and they don't show much washout on CT and MR. They may actually show delayed enhancement because of that. We don't see them in the ultrasound contrast, so these lesions show complete washout. We actually do more kidney cases than liver cases. All of the contrast agents are not excreted, so there's no contrast within the collecting system. Any benign cystic lesions, no matter what the Bosniak classification is, do not have enhancement. And malignant cystic lesions have enhancement of the cyst wall, septations, or nodules. And usually renal cell carcinomas have rapid enhancement and washout. And again, if we look at this table, I think interpretation of the kidneys is a little bit easier. If there's no enhancement, it's benign. If there's enhancement, it's probably malignant. The only cases that would show vascular enhancement are an angiomyolipoma. And we think we can distinguish an angiomyolipoma from an echogenic renal cell because the echogenic renal cells tend to have rapid, uniform enhancement, where the angiomyolipomas are somewhat like a hemangioma in the liver. They kind of just flow globular enhancement in the areas with fat don't enhance, and it usually doesn't enhance more than the normal cortex. And obviously, if you have an infection, you may see vascularity in that, but usually we don't see those cases because they're diagnosed clinically. In cases with necrosis, you won't see any enhancement centrally within the lesion. So we published our literature series of our first about 1,000 patients. And we followed them for 10 years. Ultrasound had a sensitivity of 100% and a specificity of 95%, a positive predictive value of 95%, and a negative predictive value of 100%. And I think it's real important that, again, with this negative predictive value, and this was the time that we had definitive proof, but we've now followed all those cases, which were about 700, that almost 10 years for all of them, and none of them have converted to renal cells. So with this negative predictive value of 100%, we think we can confidently call them benign. We may not even need to have follow-up. We need some additional studies to confirm that. But just to show you again the difference between a benign and malignant, and it's regardless of the Bosniak classification. If you see septations or nodules in the lesion, they'll just show no enhancement at all if they're benign, and all of the septations and nodules will enhance if they're malignant. So very easy distinction. And again, with the angiomyolipomas, the angiomyolipomas tend to not enhance as much as the normal kidney in the arterial phase and often have a globular appearance. And they often, again, because they're very echogenic, wash through at the very end. The renal cell carcinomas tend to have relatively uniform marked enhancement greater than the kidney. And again, we always try to get a CT or MR to confirm that there's fat, to confirm that it's an angiomyolipoma. So the protocol we used when we did our study was no flow and the lesion was benign. Occasionally you'll see one bubble going across the septation, and we call that benign. And initially we called a constant flow of bubbles without nodularity indeterminate, but we've now followed them and they're all benign. However, if you see nodularity, then we consider that malignant. If you have enhancement equal to normal cortex in all enhancement phases and you see the presence of a central pyramid. So here, again, we don't have excretion, so we don't see the pyramids being very contrast enhanced. In fact, they have less blood flow than the cortex. So we usually can see them and we can confirm that it's a fusion abnormality if we can see that medullary pyramid within that area. Echogenic mass, we talked about that, and again, any other mass with blood flow we considered malignant. So some examples, and again, a big application of this is people that cannot get contrast. So CT without contrast, there's obviously something funny about this kidney. When we do the ultrasound with contrast, you can see that there's a large enhancing mass with an area of central necrosis that was a renal cell carcinoma. And again, here you can see we can make out the medullary pyramids within the cortex because they have less blood flow, and the collecting system shows no enhancement. An enhanced MRI of a complicated cystic mass, I think you would struggle to decide if there's a little enhancement in this mass or the septation's enhancing. But an ultrasound contrast, in the same case, you can see that this mass shows no enhancement and was a hematoma. And if you look at the septations, you see these little berries of enhancement, which are tumor nodules. So it's very easy to make the diagnosis of a cystic renal cell carcinoma. Another case with septations, again, MR without and with contrast. Yes, we see the septations better with contrast, but are they malignant? And here again, ultrasound, and here's the ultrasound with contrast, and you can see these areas of enhancement, which are small tumor nodules in the cystic renal cell carcinoma. So another case, I think once you have one of these, you really, your urologist will consider ultrasound contrast very valuable. So this patient came in for a renal stone protocol and had two renal masses. So they were both on the same plane, a right and a left, and they looked identical on the CT, on the without, the portal venous, and the delayed. But when we injected this patient, the mass on the right showed marked enhancement and was a renal cell carcinoma. Lesion on the left showed no enhancement and was a benign cyst. So you can really differentiate these, and I think you probably all realize that papillary cancers are sometimes very difficult with CT and MR because they don't show enhancement, and the background tissue it blocks things. So here we don't have the background tissue. We can see the enhancement, and actually in a lot of these we see marked enhancement very early, but it only lasts for a few seconds. So because we're filming with that high frame rate, we can see that. And if you have the timing wrong on CT and MR, you completely miss it. This was actually one of our orthopedic surgeons who was playing hockey and got whacked. And you can see he has some mass and there's some excretion in the kidney. We did our ultrasound with contrast. There's absolutely no flow within this lesion. And for sure, this is just a benign complicated cyst. And actually, if he was active bleeding, we would actually see the bubbles flowing. So it adds a little bit of information. I left the signature on here. This is ATL. So this was one of the first cases we did probably almost 20 years ago. It was a transplant kidney, and my partner did an angioplasty because the patient had a renal transplant stenosis. And when he did the angioplasty, he noted a blush in the kidney. And they did a CT and an MR with contrast that were normal. And they sent the patient to us because, again, we were trying to enroll patients, and I was driving the urologist crazy to send me patients. And here you can see, here's the transplant kidney, that we saw this markedly enhancing mass in the kidney to correspond to what they saw in angiography, but it only lasted for about 5 seconds before it went down, became more like the normal kidney. So that's why they couldn't see it on CT and MR. We were able to biopsy it using ultrasound contrast to guide us, and then we actually did an RFA using ultrasound contrast. And here you can see after the RFA, there's no blood flow in the lesion, and we ablated the tumor. Again, patients without contrast. This was someone else that we did an RFA on that also had an aortoiliac stent graft, and they were following the graft with CT without contrast. So when we did him for our renal ablation, we noticed that there was almost a 1 centimeter gap in the stent, and there was huge amounts of ultrasound contrast pouring into this aneurysm. This is really nice because, again, you can cine back and actually see where the blood flow is coming out. So here we've got this type 3 endoleak where the graft is not attached to the aorta. We use ultrasound contrast for guiding our RF ablations because we've trained the anesthesiologist to give the contrast. One thing you have to remember is the anesthesiologists like to inject way at the top by the saline bag. If you do that, the contrast is too diluted when you do the exam. So they have to put a port down by the hand and inject there when you do this. But as we do an ablation, we do a post-contrast examination. And here you can see I've ablated, this is a renal cell carcinoma, this part of the tumor, but there's still marginal enhancement here, so we know that there's still viable tumor. And here we can now reposition the needle in the areas with enhancement and do ablations so that we confirm at the time we do this that we get the entire tumor. Again, ablated on the CT, is there any residual contrast or any, is there any residual tumor here? Very difficult to tell. On the ultrasound with contrast, the ablated area and the tumor show no bubbles at all, and this is a completely ablated tumor. I added this in since you guys are very interested in breast. Here you can see there's marked enhancement of the lesion. In general, there's not a lot of blood flow to the breast, so we usually do a double dose. In general, the lesions, benign lesions tend to have vessels that drape around the outside. The malignant lesions tend to have vessels that go in perpendicular to the lesion. So we can see these things, and we can also see there's significant enhancement surrounding the tumor. And actually, if you compare this to elastography, this almost corresponds to that enlargement we see with elastography. So that may provide us some more information. And again, sometimes you can see a little brush border, a little hairy vessels coming into the lesion, suggestive of malignancy. So the one advantage that we see with this for breast is if you're doing neoadjuvant chemotherapy and you want to see if it's working, you can now do quantification and actually see if you're decreasing the tumor vessels. For diagnosis, we really don't add it because, like I said, we really like to use elastography for that. In terms of costs, there's one study that was done in Europe that shows that you can do these exams for much less than CT and MR. Some of these numbers are pretty unrealistic for North America, but I think we can do this. And I think the one issue that we have in North America is that we're not allowed to give contrast unless we have an order. So sometimes we see a mass on the screening examination that we would like to give the contrast right away and make the diagnosis. We have to call the doctor, and it's a long process. In Europe, they don't have to do that, so they just routinely inject and answer it. And in the studies that they've done, about 85% of the time, they can make a diagnosis, and they don't need any additional examination. So it saves the patient time, and it saves a lot of money. We don't do pediatrics, but it's approved in the United States for urinary reflux. So very similar to doing iodated contrast and then following with fluoroscopy. Here you inject the bubbles into the bladder and you just look over the kidneys and the distal ureters to see if you see the bubbles. So no radiation and can be done, and it's just as efficient and sensitive as doing it with radiation. There's guidelines by both WFM and EFSM, and the WFM guidelines are going to be updated next year. There's ones for hepatic use and there's ones for non-hepatic use. And I think that there are a lot of other applications to be used, and the WFM guidelines for non-hepatic uses go a whole list of a bunch of different organs that you may want to look at. They may be helpful. With training, so in the U.S., Bronco is having some training courses. I don't know if they're doing that here, but we're a training site for them, and people come to our center and we do hands-on training. There's also courses available in Europe, and there is also an organization called ICUS, ICUS, International Contrast Ultrasound Society, that's based in the U.S. in Chicago, and they offer training courses in this. Right now, I think all the training courses have been in the United States, but I think they're thinking of moving the courses out to the rest of the world. So, again, if you're going to start this, you need to talk to your referring doctors. Again, our urologists don't believe CT and MR now. We do mostly kidneys, and I think that once your urologists see that you can help them out, you'll get referrals. Our oncologists, like I said, we've had problems because it's not in their standard protocol, and they feel there's legal issues if they do this and not do the routine. But all of our doctors in our area know we do this, and in those problematic patients that they don't have an answer from CT and MR, or the patient can't get contrast, these patients are referred to us. These are really their contraindications were this right to left shunt or whatever. This has now been removed by the FDA. So really the only contraindication right now is hypersensitivity to the agent or contrast parts of the agent. Occasionally we have people that complain of headache or back pain, usually resolves before we're done with the examination. I know of one case that somebody had a life-threatening reaction somewhere else. So they can happen, so you need to be prepared. If you look at the literature, the adverse events are much less frequent than in CT and MR, but like I said, you still need to be prepared in case there isn't a problem. So ultrasound contrast increases sensitivity and specificity over a non-enhanced ultrasound. It has similar specificity and probably increased sensitivity than enhanced CT and MR. It's less expensive, and you can differentiate liver malignant pathology lesions based on the rapidity of washout. And like I said, kidneys are our biggest examination, and I think that you will find that a lot of these, particularly in the papillary renal cell carcinomas, you can easily make the diagnosis where oftentimes they're missed in CT and MR. This is a safe examination without ionizing radiation and can be used in case of renal impairment and obstruction because it's not excreted. You don't have to worry if they have hydronephrosis. And in patients with contraindications for enhanced CT or MR. Again, the real-time assessment and narrow slice thickness are huge advantages over CT and MR. And again, liver and indeterminate renal lesions, accuracies at least as good as CT and MR. And again, I look at this as an important imaging addition to our toolbox, so we use it in the selected patients where we think it's going to help. Thank you.